Hi, in today's video, I'm going to be talking about a phase of dying that's referred to as actively dying. It's normally about 3 to 5 days before death and is characterized by a lot of physical changes. I'll go over 7 of those changes and then I will talk about some things that you can do if you're with somebody in this phase of dying to bring comfort, and then share a personal story about some of these things. Hi, I'm Nancy Lee. I'm a nurse practitioner, and I have spent the last 25 years of my career working with patients and their families who are at or near end of life. So, actively dying, again, like talked about initially, it is about 3 to 5 days before death. It can be a little shorter and it can be a little longer. I want to go over some of the physical findings that makes this stand out. And the first one, and the most obvious one, is a change in level of consciousness. And what that means is that the patient is no longer actively awake or responding verbally. There may be sporadic moments of arousability, but for the most part, the patient is unarousable. They are no longer eating or drinking. Now, I want to say something here. IV fluids are not indicated. Our bodies are miraculously made. And when we're actively dying, our bodies are trying to shut down and reserve all those core mechanisms that keep us alive are beginning to shut down. To introduce IV fluids into the vascular system causes tremendous suffering. Those fluids do not go where they're supposed to go. They do, however, accumulate in the lungs, the legs, the arms, and just generally all over the body, and leads to mostly a lot of discomfort with breathing. Over the years, I've had a couple of families not believe me when I've told them this and pushed me to do it. And within an hour, they are begging me to stop the IV fluids because they see for themselves the distress that it produces. So not eating or drinking, our bodies are designed to do that. At this phase, actively dying, people become completely dependent in what we call ADLs, or activities of daily living. Because they're no longer eating or drinking, what I'm referring to here is that they're completely dependent for toileting and movement. They are unable to move themselves. So they will stay in the exact same position for this entire time, for days at a time, unless they are moved with gentleness and, intent. Another physical finding is incontinence. They may be incontinent, well, they definitely will be incontinent of bladder or bowel, or they may have no elimination at all. Breathing changes is the next thing I want to talk about in an actively dying patient. Breathing becomes very erratic. It will go from rapid, shallow breaths to deep, prolonged breaths, and then to not breathing at all. And you'll think the person has passed on, only to take a big gasp of air and to continue to breathe. So these breathing changes go back and forth during these days until the final end of life, when they just don't take another breath. There are vasculature or circulation changes that manifest as cool skin. There may be purple discoloration in the hands and the feet. Their pulses in their hands and their feet are no longer present. That is very normal as someone is actively dying. Now, some of the things that I think bring comfort to an actively dying patient are: number one, to stop medical touch. In other words, no more vital signs, no more blood pressure, no more pulse oximeter, except for maybe a spot check once a day, and not blood pressure. I would never take. I don't like having my blood pressure taken, and I'm healthy. I definitely don't want somebody putting a cuff on me when I'm trying to make my transition. So we can tell a lot from a pulse oximeter, and I highly discourage families from looking at the patient as vital signs related and just look at them as a human being. making their transition and reserving touch to loving, gentle stroking, kissing on the forehead. I want you to know that when people are making their transition from the physical to the non-physical, they have to physically separate. And every time we touch them, now this has just been my observation, it seems as if we bring them back into their bodies. So just letting them do their own process to be punctuated by some loving touch is what I always recommend. The next thing I would say is to talk to the person as if they can hear you, because it will appear that they cannot hear you. I have heard families start to talk about funeral plans, and I go, hold on a minute, let's step outside and have a talk. And I share with them that your loved one can likely still hear them. Let's talk about something, maybe perhaps about memories of your time together. The other thing I would say is I often, I'll run into family members who have some sense of great grief or sadness. And I find that if I can talk to them and counsel them about reassuring the person that's dying what a wonderful role that they played in their life as their mother, brother, sister, friend, that brings healing probably to the person who's dying, but also to the person who's accompanying this part of that person's journey. I'll talk to families about sitting at the bedside or actually on the bed with family photos and go through those photos, because that always stimulates conversation about memories and reminiscing. And last thing I will say is make sure that you are advocating for your loved one or your family member's comfort by providing or having the medical team provide scheduled medication for pain or breathlessness. Remember that this person can no longer communicate, and I'm gonna just believe or err on the side that perhaps that they are in pain or having some kind of discomfort. It can just be breathing, which becomes very obvious in a lot of patients who are actively dying. But to provide medication on a scheduled basis, and when I say medication, I mean a narcotic, either morphine or any other narcotic, Dilaudid, that can be given sublingually or if they have IV access through an IV, that it should be scheduled. It should not be on an as needed basis, because the person can't say, hey, I'm hurting. There are nonverbal signs of pain that can be evident. And if those become evident on a scheduled medication schedule, then the medication dosage needs to be adjusted upward. So I think that's really important. And then lastly, I want to share with you a personal story about how I really believe that an unconscious, actively dying person can hear you. And it's with my mother, who was actively dying, unresponsive in a hospital setting. I was a relatively young nurse. I was really close to my mom, and she died much too young of pancreatic cancer. I was sitting at her bedside, and I thought, I've been taught all these years that people can hear you even if they're unconscious. So is there anything left that I need to say? And I thought back to the years of being a teenager, and I picked at my mom and I argued with her a lot. And I took her hand and I said, I'm sorry I wasn't a better daughter. Not really believing that she could hear me. And I'm telling you, she turned her head, and I was unable to wake her before this. She turned her head, opened her eyes, looked at me and said, you were wonderful. You were wonderful. That was one of the best gifts of my life. And it cemented for me that unconscious patients can in fact hear you. She was not going to leave this life with me thinking that I had not been a good daughter. So keep that in mind if you're with someone that is in the actively dying stage. Just remember that they can in fact hear you. likely. Please like, comment. It helps my channel a lot, and I'm really trying to grow this channel right now. And subscribe. But if you have stories about being with an actively dying patient, that's a very sacred part of somebody's life. I encourage you to share them. If you have questions, I'm happy to answer those in the comments. And thank you so much for watching. I'll see you next time.